the muscles of the rotator cuff. Before we begin, I'd like to give you a quick overview of what we're going to be talking about in this tutorial. So firstly, we're going to be looking at the bones that make up the shoulder joint, as they form the bony framework that our muscles attach to. And then I'll give you a little introduction to the muscles of the rotator cuff as a whole, before we go on to look at each muscle individually, discussing their origin, insertion, function, and innervation. And finally, we'll conclude our tutorial with some clinical notes about dislocation of the shoulder joint. Okay, so let's get started with the bones of the shoulder joint. So as I mentioned earlier, the shoulder joint is the most mobile joint in the human body. And this is down to the fact that it's a synovial ball and socket joint, which we can see here from an anterior perspective. The ball component of this joint is formed by the head of the humerus, which is a feature of the long bone in our arm, the humerus, whereas the socket component is formed by the glenoid cavity, which is part of the scapula or the shoulder blade. And as such, the shoulder joint is also known as the glenohumeral joint. Okay, now that we're familiar with the bony framework that our muscles attach to, let's move on and have a look at the muscles of the rotator cuff. So before we get on to the details, let's orientate ourselves. And here we have our lovely KenHub volunteer. Let's call her Annie. And we can see her from both a posterior perspective and an anterior perspective. So if we remove Annie's skin, connective tissue, neurovasculature, and some surrounding musculature, thank you, Annie, we can see her rotator cuff muscles. And posteriorly, we have the supraspinatus, the infraspinatus, and the teres minor, and anteriorly we have the subscapularis. So now we're going to get Annie to stand side on for us, and we're going to remove some of the surrounding soft tissues and the humerus. And here we can see all four rotator cuff muscles. And again, we can see the supraspinatus, the infraspinatus, and the teres minor posteriorly, and we have the subscapularis anteriorly. A useful tool to help you remember the muscles of the rotator cuff is the phrase, the head of the humerus sits in the glenoid cavity, with sits being a handy little mnemonic for you to use here, with S standing for supraspinatus, I standing for infraspinatus, T standing for teres minor, and S standing for subscapularis. Okay, so now that we know what we're looking at, let me give you some information about these muscles as a whole. So generally, the muscles of the rotator cuff originate from the scapula, and they insert at the humerus, which is at this point over here. As for their functions, these muscles work together to reduce the risk of dislocation by stabilizing the shoulder joint. Essentially, they help keep the head of the humerus in its correct position within the glenoid cavity, and also, as the name suggests, the rotator cuff muscles play a major role in medial and lateral rotation of the arm at the shoulder joint. So now that we're familiar with the rotator cuff muscles as a whole, let's look at each muscle individually. And we're going to be discussing their origin, their insertion, their function, and their innervation. So the first muscle that we're going to be talking about is the supraspinatus, which we can see here highlighted in green. And as the name suggests, this muscle originates from the supraspinous fossa of the scapula, which is a shallow depression in the body of the scapula above its spine. It then goes on to insert here at the greater tubercle of the humerus. So when the supraspinatus contracts, it initiates abduction of the arm at the shoulder joint, and as a rotator cuff muscle, it also stabilizes the shoulder joint. And of course, in order for this muscle to perform its functions, it requires innervation, and the supraspinatus is innervated by the suprascapular nerve, which arises from the superior trunk of the brachial plexus. Inferior to the spine of the scapula, we find the infraspinatus muscle, and this muscle originates from the infraspinous fossa of the scapula, and like the supraspinatus, it inserts over here at the greater tubercle of the humerus. As for its functions, the infraspinatus is responsible for lateral rotation of the arm at the shoulder joint, and it also stabilizes the shoulder joint. And like the supraspinatus, this muscle is innervated by the suprascapular nerve, which we can see here highlighted in green. So the next muscle of the rotator cuff that we're going to be talking about is the teres minor muscle. And this muscle originates from the lateral border of the scapula. It then runs, as you can see, obliquely upwards and laterally to insert at the greater tubercle of the humerus. Contraction of this muscle results in lateral rotation of the arm at the shoulder joint, and of course, it also stabilizes the shoulder joint. As for its innervation, the teres minor is innervated by the axillary nerve, which we can see here highlighted in green. Okay, so in order to see the last muscle of the rotator cuff, we need to change to an anterior view of the shoulder joint. And over here we can see the subscapularis muscle, which originates from the subscapular fossa. Unlike its buddies, this muscle inserts at the lesser tubercle of the humerus, as you can see here. The subscapularis is responsible for medial rotation of the arm at the shoulder joint, and it also stabilizes the shoulder joint. When it comes to the innervation of the subscapularis muscle, this muscle is innervated by the upper and lower subscapular nerves, which are branches of the posterior cord of the brachial plexus. Okay, so as we come towards the end of our tutorial, you should now be feeling comfortable with the muscles of the rotator cuff. Let's move on to discuss some clinical notes relating to the dislocation of the shoulder joint. So as I said at the start of our tutorial, the shoulder joint is the most flexible joint of the human body, which means that it's particularly vulnerable to dislocation. Because we have ways to reduce the risk of dislocation, such as our rotator cuff muscles, it requires a pretty strong force to pop this joint out of its socket. Therefore, it's normally caused by a fall or a collision with another person or an object. So most people dislocate their shoulder while playing a contact sport such as rugby, or while undertaking sports that have a potential for frequent or high-impact falls, such as gymnastics. However, in older individuals, it can also be caused by falling on outstretched hands. And most shoulder dislocations involve anterior displacement of the humeral head, which we can see here in this X-ray. So over here we can see the head of the humerus, and behind it we can see the glenoid cavity of the scapula. So symptoms of dislocated shoulder include intense pain, inability to move the joint, and visible deformation of the shoulder joint. And in terms of treatment, we can use a procedure called reduction, where the doctor rotates the arm until it goes back into its socket. And some patients damage soft tissues when they dislocate their shoulder and may need surgery to repair them. So recovery requires rest and pain medication, as well as physiotherapy to improve strength and mobility, and it can take up to 3 to 4 months to recover fully from a dislocated shoulder. Okay, so before we bring our tutorial to a close, let's quickly summarize what we've learned today. So we started our tutorial with talking about the bones of the shoulder joint, which are the humerus and the scapula. And then we talked about the muscles of the rotator cuff as a whole, before looking at each muscle individually, discussing their origin, insertion, function, and innervation. And finally, we finished up our tutorial with some clinical notes about dislocation of the shoulder joint. So that brings us to the end of our tutorial on the muscles of the rotator cuff. I hope again, though, I want to clear up an issue that often arises when transitioning from everyday terms to anatomical terms. So as a kid, your arm is your arm and your leg is your leg, but in anatomy, instead, your arm or upper limb is divided into the arm and forearm, and your leg or lower limb is divided into the thigh and leg. So when I say we're going to talk about the muscles of the arm, I mean this region here, between the shoulder and the elbow joints. Okay, now that we've got the terminology down, I'd like to give you a quick overview of what we're going to be talking about in this tutorial. First, we're going to be looking at the bones that make up the shoulder joint, as they form the bony framework that our muscles attach to. Then we'll look at the muscles of the arm, which can be divided into 2 compartments, the anterior compartment and the posterior compartment. As we talk about each muscle, we'll learn about their origin, insertion, function, and innervation. And finally, we'll conclude our tutorial with some clinical notes. So let's get started and talk about the bones of the shoulder joint. The shoulder joint is a synovial ball and socket joint, and we can see it here from an anterior perspective, highlighted in green. The ball component of this joint is formed by the head of the humerus, which is a feature of the long bone in our arm, the humerus, whereas the socket component is formed by the glenoid cavity, or fossa, which is part of the scapulae or shoulder blade. As such, the shoulder joint is also known as the glenohumeral joint. After that short but sweet introduction to the bones of the shoulder joint, let's move on now to have a look at the muscles of the arm, starting with the anterior compartment. Now, the anterior compartment of the arm consists of 3 muscles, and the first one we'll talk about is the biceps brachii. As the name suggests, this muscle has 2 heads, both with different points of origin, and the long head originates from the supraglenoid tubercle of the scapula, and the short head originates from the coracoid process of the scapula. Both heads unite to form a single large muscle belly, which inserts at the radial tuberosity. It also has a soft tissue attachment to the deep fascia of the forearm through a wide expansion of the biceps brachii tendon, known as the bicipital aponeurosis. So, what does the biceps brachii do? Well, this muscle has several functions. It's a powerful flexor of the forearm at the elbow joint, which involves decreasing the angle between the arm and the forearm at the elbow joint. It's important to note, however, that when the forearm is in the pronated position with the palms facing down, the biceps brachii loses its mechanical advantage. This means its involvement in flexion of the forearm at the elbow joint is more limited than the supinated forearm. This muscle also assists in flexion of the arm at the shoulder joint and supination of the forearm. Supination is a movement that involves the rotation of the hand and forearm so that the palm faces upwards or forwards, as demonstrated by our image here. Before we move on, let me mention some minor functions of the biceps brachii. So the long head is said to assist in abduction of the arm at the shoulder joint, which involves the movement of the arm away from the midline of the body, whereas the short head is said to facilitate in adduction of the arm at the shoulder joint, which involves the movement of the arm towards the midline of the body. Lastly, this muscle is also said to assist in internal rotation of the arm at the shoulder joint, and as you can see, this simply refers to the rotation of the arm towards the center of the body. In order for the biceps brachii muscle to perform its functions, it requires innervation, and it's innervated by the musculocutaneous nerve, which is a branch of the brachial plexus. So if we remove the biceps brachii, we can see this muscle highlighted in green, which is the coracobrachialis muscle. And the coracobrachialis originates from the coracoid process of the scapula and extends distally to insert along the anteromedial surface of the humerus. This muscle assists in flexion and adduction of the arm at the shoulder joint, and this muscle is also said to assist in internal rotation of the arm at the shoulder joint. Like the biceps brachii, the coracobrachialis is innervated by the musculocutaneous nerve, which we can see here. And the third and the last muscle of the interior compartment of the arm is the brachialis. And even though the brachialis is located deep within the arm, its large belly makes the biceps brachii look much larger on the surface than it actually is. So for that reason, we have to say that behind every great biceps, there's a great brachialis. This muscle originates from the anterior aspect of the humerus and inserts onto the ulnar tuberosity. When the brachialis contracts, it causes flexion of the forearm at the elbow joint, in particular when the forearm is in a pronated position. In terms of innervation, the brachialis is innervated by the musculocutaneous nerve, and the lateral part of this muscle also receives some innervation from the radial nerve. Okay, now that we've had a look at the anterior compartment of the arm, let's flip it over so we can see the posterior compartment. The posterior compartment of the arm consists of two muscles, and the first one we're going to talk about is the triceps brachii. And as its name suggests, the triceps brachii has three heads. The long head, seen here, originates from the infraglenoid tubercle of the scapula. The medial head, which is the smallest of the three, arises from the posterior surface of the humerus, inferior to the radial groove. And lastly, the lateral head originates from the posterior surface of the humerus, superior to the radial groove. The three heads of the triceps brachii fuse into a common tendon, which crosses the elbow joint before inserting onto the olecranon of the ulna. This muscle is responsible for extension of the forearm at the elbow joint, and the long head also performs extension and adduction of the arm at the shoulder joint. So when it comes to innervation of the triceps brachii, this muscle is innervated by the radial nerve, and although the triceps brachii is the main muscle of the posterior arm, there is another muscle found in this region, which is often overlooked, and this muscle is the anconeus muscle, which you can see now highlighted in green. The anconeus is a small triangular-shaped muscle found around the elbow region, and it lies superficially and can be easily palpated at the posterolateral side of the forearm near your elbow. And this muscle originates from the lateral epicondyle of the humerus and inserts at the olecranon of the ulna. When the anconeus contracts, it assists in extension of the forearm at the elbow joint, and extension of the forearm at the elbow joint involves increasing the angle between the arm and the forearm at the elbow joint. The innervation of the anconeus is supplied by the radial nerve. It's worth noting that the triceps brachii and the anconeus are not only innervated by the same nerve, but they're also often found either partially or completely blended together. Therefore, they sometimes may appear as one muscle in dissection. Okay, so now that we're familiar with the muscles of the arm, let's get clinical. So linking back to our introduction, today's clinical notes will discuss the issue of anabolic steroids. So during your medical training, you might have come across treatment plans involving steroids. Corticosteroids are often prescribed by doctors to reduce inflammation, but they are not anabolic steroids. Anabolic steroids are synthetic hormones that resemble the male sex hormone testosterone. And like corticosteroids, they have some medicinal purposes. However, they can also be used illegally by bodybuilders and other athletes to help promote muscle growth and enhance performance. Taking you from this to this. Sound appealing? Well, think again, because anabolic steroids have many serious side effects. Let me list some of them for you now. Severe acne, hair loss, liver disease, kidney disease, heart disease, altered mood, breast development or gynecomastia in males, facial hair in females, infertility, and even death. So, although steroid users may be thrilled with their outer appearance, they may also be causing serious damage to their insides. Therefore, if you want to become swole, be smart and stick with the diet and exercise regime. Leave the steroids for the doctors to prescribe. Okay, so before we begin our tutorial to a close, let's quickly summarize what we've learned today. So we started off by talking about the bones of the shoulder joint, which are the humerus and the scapula. Next, we moved on to talk about the muscles of the arm, which we divided into two compartments, the anterior compartment and the posterior compartment. And finally, we concluded our tutorial with some clinical notes about anabolic steroids. So that brings us to the end of our tutorial on the muscles of the arm. I hope you enjoyed it. Thanks for watching and see you next time.
As well be able to at least name the muscles in question, and that's exactly what we're going to be doing today. So whether you're showing off the fruits of your many shoulder and arm workouts or just trying to ace your next upper limb anatomy exam, stay tuned as we explore the muscles of the arm and shoulder. So to get started, let's first remind ourselves of the bony framework, which provides the attachment points for the muscles that we meet today. As you see here in this illustration, we are looking at the posterior surface of the humerus, which of course is the long bone of the arm. On the left side, you can see this triangular shaped bone, which we know is the scapula, also commonly referred to as the shoulder blade. In this tutorial specifically, we will be introducing you to the muscles that have their attachment points on or between these two bones. The aim of the game today is to help you learn how to identify the muscles by their location and attachment points. If you need more detailed information in regards to specific functions and innervation of each muscle, please be sure to check out our more in-depth videos on the muscles of the shoulder and muscles of the arm. We're going to begin this tutorial now by first exploring the muscles of the arm region. First point to make here is that these muscles can be split into two groups. The first one belongs to the anterior or ventral compartment of the arm and includes the biceps brachii, coracobrachialis, and brachialis muscles. Also, you can find another group which belongs to the posterior or dorsal compartment, which includes the anconeus and also the triceps brachii muscle. Now let's start with the anterior or ventral group, beginning first with this muscle, which you see here highlighted in green. This, we all know, is the biceps brachii muscle. Now, true to its name, the biceps brachii has two heads, a short head located medially, as you can see here, and a more lateral long head seen here. Each head of the biceps brachii has a different origin or proximal attachment point. In the case of the long head, you can see it is originating right here from what's known as the supraglenoid tubercle of the scapula. In regards to the short head, you see that the origin point is located right here on this distinct looking projection of bone, which is known as the coracoid process of the scapula. As they continue distally, the two heads of the biceps brachii merge into a single belly, which continues to insert right here on the radial tuberosity of the radius. The biceps brachii also attaches to some soft tissue of the forearm, which is known as the antebrachial fascia. Now let's move on to the second member of the anterior group, which is this muscle here that you see now highlighted in green. Now, can you guess what this muscle is? I'll wait a few seconds. Tick-tack. Yes, it is indeed the brachialis muscle. The brachialis originates here from the distal half of the anterior surfaces of the humerus and also the medial and lateral intermuscular septum. In contrast to the biceps brachii, the brachialis has its insertion or distal attachment on the ulna, specifically onto its coronoid process and ulnar tuberosity. The third muscle of the anterior compartment is this small muscle here, which is the coracobrachialis muscle. And as its name suggests, the coracobrachialis has its proximal attachment point or origin at the coracoid process of the scapula. And from here, it extends distally along the humeral shaft to then insert along the anteromedial surface of the humerus. And just like that, my friends, we have discussed the interior muscles of the arm. It is literally as easy as 1, 2, 3, hopefully. That means it's time to turn our attention to the posterior or dorsal group, beginning with the first muscle on our list here, which is the triceps brachii. As its name suggests, the triceps brachii muscle has 3 heads. So there is the long head seen here, which has its origin or proximal attachment at the infraglenoid tubercle of the scapula right here. There is also a medial head, which is the smallest of the 3, arising from the posterior surface of the humerus, distal to the radial groove, and medial intermuscular septum. The third one is the lateral head, also has its proximal attachment on the posterior surface of the humerus, however this time proximal to the radial groove and the lateral intermuscular septum. The 3 heads of the triceps brachii fuse into then a flat common tendon which crosses the elbow before inserting into the olecranon process of the ulna. Although the triceps brachii is by far the dominant muscle on your posterior arm, there is another small muscle to be found in this region, which is often overlooked, and that muscle is the anconeus muscle, now highlighted for you on the screen. As you can see, it is relatively small, triangular shaped muscle, which in reality is often blended with the lateral border of the triceps brachii tendon. And it too attaches to the proximal end of the ulna. We're going to continue proximally now towards the shoulder joint, where we have a number of muscles to examine, beginning first with this one here, which is of course the deltoid muscle. The deltoid muscle is the most superficial muscle of the shoulder joint, and therefore it's this muscle which gives most definition to our shoulders. So if you see someone with beautiful shoulders, you know what muscle to blame it on. The deltoid muscle has 3 subdivisions or parts based on its origin or proximal attachment points, and you will see in a moment that the name of each part gives us a clue to the attachment point in question. Beginning anteriorly, we have the clavicular part of the deltoid, which is attached, you can guess, to the lateral third of the clavicle. Looking now from a posterior perspective, we can see the acromial part that originates from the acromion of the scapula. You can see how the naming here works. We like to simplify things in anatomy. And finally, the scapular spinal part, which again, true to its name, presents its origin along then the spine of the scapula. Now, if we remove the large deltoid muscle like this, we can now get a better view of the muscles lying deep to it. There are 5 muscles here for us to consider, 4 of which belong to what's known as the famous rotator cuff, which if you've ever had a shoulder injury, you probably know all about it. The muscles of the rotator cuff share a common feature in the sense that they all insert or have their distal attachment somewhere on the proximal end of the humerus. Because of that, they help support the shoulder joint by keeping the head of the humerus in its correct position within the glenoid cavity. From an anterior perspective, we have just one rotator cuff muscle to consider, and that is the subscapularis muscle. As its name suggests, the subscapularis muscle has its origin across the entirety of the subscapular fossa of the scapula. As you can see in the illustration, the large belly of the subscapularis tapers off as it reaches its insertion, which is generally located on the lesser tubercle of the humerus. Flipping over to the posterior aspect now, the second member of the rotator cuff is the infraspinatus muscle, which originates from the infraspinous fossa of the scapula. It extends laterally where it has its distal attachment along the posterior aspect of the greater tubercle of the humerus. And moving inferiorly, we find our third member of the rotator cuff, which is known as the teres minor muscle. It originates from the infraspinous fossa and lateral border of the scapula and finds its insertion just distal to that of the infraspinatus on the posterior aspect of the greater tubercle of the humerus. And finally, muscle number 4 of the rotator cuff is this one here highlighted in green for you, and it's called the supraspinatus muscle. This muscle originates from the supraspinous fossa of the scapula and reaches across over the head of the humerus to insert here at the greater tubercle. And there you have the 4 muscles of the rotator cuff. A little tip to help you remember the 4 members of this group is to always remember that the head of the humerus sits in the glenoid cavity, with sits being a handy little mnemonic for you to use here. We have just one more muscle to discuss here, and that is the big brother of the teres minor, which is appropriately known as the teres major muscle. As you can see in the illustration, the teres major muscle has its origin right here around the inferior angle of the scapula. It has a longer belly than its little brother, which reaches anterosuperiorly to insert along the anterior aspect of the humerus, specifically the crest of the lesser tubercle. And that concludes our introduction to the muscles of the shoulder and arm. Before we finish our tutorial, let's have a final look at some of the muscles we saw today from a clinical perspective. So just a few moments ago, we identified these 4 muscles as the members of the rotator cuff. And for those of you who work out, play sports, or physically use your arms a lot in your work, you're probably very familiar with the term rotator cuff injury. There are 3 main types of rotator cuff injury. Tendinitis, which is usually caused by overuse of the rotator cuff. This results in inflammation of the rotator cuff tendons. Tennis players and painters are commonly affected in this way and typically experience a consistent dull aching pain around the shoulder joint. The second type is bursitis, which involves inflammation of the subacromial and subdeltoid bursae. And finally, we have strains and tears of the rotator cuff, which are caused by overuse or acute trauma to the shoulder joint. The tendons of the rotator cuff muscles may be overstretched or torn, partially or completely. Now, these types of rotator cuff injury cause the most immediate and intense pain for sure, and sometimes require surgical intervention. There are some actions which we can take in order to prevent rotator cuff injuries, starting off with daily shoulder stretches to increase flexibility of the shoulder joint. Also, many people who work out tend to focus on the anteriorly positioned muscles of the chest, arm, and shoulders. However, if you remember from earlier, many of the rotator cuff muscles are located posterior to the shoulder joint. And this means it's important to strengthen the muscles around the shoulder blade and posterior shoulder specifically to optimize the muscle balance of the rotator cuff. And with that, we have reached the end of our tutorial. Let's wrap up with a quick summary of what we have learned today. We began our study with the muscles of the anterior compartment of the arm, which included 3 members: the biceps brachii with its long and short heads. Then we looked at the brachialis muscle, and finally the coracobrachialis muscle. We then flipped over and identified 2 muscles of the posterior compartment of the arm, which were the triceps brachii with its long, medial, and lateral heads, and the small anconeus muscle located here in the distal arm. We then quickly went on to the muscles of the shoulder joint, beginning of course with the large and superficial muscle of the shoulder, that is the deltoid muscle. We identified its three parts, which were the clavicular, acromial, and spinal scapular parts. We then looked at four muscles, which together form the rotator cuff group. These included the subscapularis muscle. We also saw the infraspinatus muscle, the teres minor muscle, and finally the supraspinatus muscle. Don't forget that these muscles can be remembered using the mnemonic SITS or SITS. This left us with just one last muscle to identify, which was the teres major muscle. And that's it. I hope you enjoyed this introductory tutorial to the muscles of the arm and shoulder. Remember to check out our other videos at KenHub, and as well as other quizzes, articles, cross-section, and lots more that you can use to learn anatomy and histology. Thanks for watching, and I will see you next time.
Of the shoulder joint. Before we begin, let me give you a quick overview about what we're going to cover in today's tutorial. First, we're going to look at the bones that make up the shoulder joint as they form the bony framework that our muscles attach to. Then we'll look at the muscles of the shoulder joint, discussing their origin, insertion, function, and innervation. Finally, we'll conclude our tutorial with some clinical notes. So let's get started and talk about the bones of the shoulder joint. The shoulder joint is a synovial ball and socket joint, and we can see it here from an anterior view highlighted in green. The ball component of this joint is formed by the head of the humerus, which is a feature of the long bone in our arm, the humerus, whereas the socket component is formed by the glenoid cavity, which is part of the scapula or shoulder blade. As such, the shoulder joint is also known as the glenohumeral joint. After that short but sweet introduction to the bones of the shoulder joint, let's move on to have a look at the muscles of the shoulder joint. A popular circus act that some of you might have seen is the world's strongest man lifting insanely heavy weights or even people. One of his muscles, which will have been particularly noticeable, are these ones you see here, the deltoid muscles. The deltoid is the most superficial muscle of the shoulder joint. Therefore, it's the muscle that defines the round contour of our shoulders. Let's move on to some KenHub illustrations. If we dissect the skin and connective tissue away from the shoulder and arm region, we can see the deltoid and associated muscles more clearly. Here we're looking at the deltoid from an anterior perspective. Before we go on to discuss the attachment points of this muscle, it's important to know that the deltoid has three parts, which are named based on their origin. Anteriorly, we have the clavicular part, which originates from the lateral third of the clavicle. And if we change views so that we see the deltoid from a posterior perspective, we can see the acromial part, which originates from the acromion of the scapula. Finally, we have the spinal part, which again, true to its name, originates from the spine of the scapula. These three parts converge towards their insertion point, which is the deltoid tuberosity found on the lateral surface of the shaft of the humerus. So what does the deltoid muscle do? Well, it's actually responsible for several movements of the shoulder joint. Each part of the deltoid performs a different function. The clavicular part flexes the arm at the shoulder joint. The acromial part is the main abductor of the arm. And the spinal part extends the arm at the shoulder joint. In order for the deltoid to perform its functions, it requires innervation. It's innervated by the nerve you can see here highlighted in green, which is the axillary nerve. Let's move on to have a look at the muscles I mentioned at the beginning of our tutorial, the rotator cuff muscles. Before we look at each muscle individually, I'll give you some information about these muscles as a whole. So here we have a posterior view of the shoulder joint and an anterior view of the shoulder joint, which together show us the four rotator cuff muscles. Posteriorly, we have the supraspinatus, the infraspinatus, and the teres minor. And anteriorly, we have the subscapularis muscle. Generally, the muscles of the rotator cuff originate from the scapula and insert at the humerus here. As for their functions, these muscles work together to reduce the risk of dislocation by stabilizing the shoulder joint. Essentially, they help keep the head of the humerus in its correct position within the glenoid cavity. Also, as the name suggests, the rotator cuff muscles play a major role in medial and lateral rotation of the arm at the shoulder joint. So the first muscle of the rotator cuff we'll talk about is the supraspinatus. As the name suggests, this muscle originates from the supraspinous fossa of the scapula, which is a shallow depression in the body of the scapula above its spine. It then inserts here at the greater tubercle of the humerus. In terms of function, this muscle initiates abduction of the arm at the shoulder joint. Then the deltoid takes over. As a rotator cuff muscle, it also stabilizes the shoulder joint. The supraspinatus muscle is innervated by the suprascapular nerve, which arises from the superior trunk of the brachial plexus. Inferior to the spine of the scapula, we find the infraspinatus muscle. This muscle originates from the infraspinous fossa of the scapula, and like the supraspinatus, it inserts here at the greater tubercle of the humerus. Contraction of this muscle causes lateral rotation of the arm at the shoulder joint, and it also stabilizes the shoulder joint. This muscle is innervated by the suprascapular nerve, which we can see here highlighted in green. The next muscle of the rotator cuff we're going to talk about is the teres minor muscle. This muscle originates from the infraspinous fossa and the lateral border of the scapula, and inserts at the greater tubercle of the humerus. This muscle is responsible for lateral rotation of the arm at the shoulder joint, and it also stabilizes the shoulder joint. As for innervation, teres minor is innervated by the axillary nerve. To see the last muscle of the rotator cuff, we need to change to an anterior view of the shoulder joint. Here we see the subscapularis muscle, which originates from the subscapular fossa. Unlike its buddies, this muscle inserts at the lesser tubercle of the humerus, as you can see here. Contraction of the subscapularis results in medial rotation of the arm at the shoulder joint, and it also stabilizes the shoulder joint. When it comes to the innervation of the subscapularis muscle, this muscle is innervated by the upper and lower subscapular nerves, which are branches of the posterior cord of the brachial plexus. And there you have it, the muscles of the rotator cuff. In this image, we can see the scapula from a lateral perspective, which allows us to see all four of these muscles. Posteriorly, we have the supraspinatus, the infraspinatus, and the teres minor. And anteriorly, we have the subscapularis muscle. A useful tool to help you remember the four members of this group is the phrase, "the head of the humerus sits in the glenoid cavity," with sits being a handy little mnemonic for you to use here. Earlier we talked about the teres minor muscle, and if you have a teres minor, then you must have a teres major. Here we see this muscle from a posterior perspective, and we can see that it originates from the inferior angle of the scapula. It then goes on to insert at the crest of the lesser tubercle of the humerus. This muscle is responsible for medial rotation of the arm at the shoulder joint and extension of the arm at the shoulder joint. Now we're going to talk about the innervation of the teres major muscle. It's innervated by the subscapular nerve, which we can see here highlighted in green. Before we move on, I'd like to mention three anatomical spaces that are defined by some of the muscles we've already talked about. First, we have the triangular space, which I've outlined for you here. The superior border of this space is formed by the inferior border of teres minor. The inferior border is defined by the superior border of teres major, and the lateral border is formed by the medial border of the long head of the triceps brachii muscle. The triangular space transmits the circumflex scapular vessels. Next we have the quadrangular space. Again, I've outlined this space for you so that you can see it nice and clearly. The superior border of this space is formed by the inferior border of teres minor, and the inferior border is defined by the superior border of teres major. The lateral border is formed by the surgical neck of the humerus, and the medial border is defined by the lateral border of the long head of the triceps brachii muscle. The quadrangular space transmits the axillary nerve and the posterior circumflex humeral artery. Finally, we have the triangular interval. As we can see in this illustration, the superior border of this space is formed by the inferior border of the teres major, the lateral border is formed by the surgical neck of the humerus, and the medial border is defined by the lateral border of the long head of the triceps brachii muscle. The triangular interval transmits the profunda brachii artery and the radial nerve. Okay, now we're going to talk about a few muscles that aren't found in the shoulder region but act on the shoulder joint. The first one we'll talk about is the pectoralis major, which is a muscle of the pectoral region. Like the deltoid, it's made up of 3 parts which are named based on their origin. First we have the clavicular part, which originates from the medial half of the clavicle. Next is the sternocostal part, which originates from the sternum and the 2nd to 6th costal cartilages. And finally we have the abdominal part, which originates from the anterior layer of the rectus sheath. These 3 parts come together to insert at the crest of the greater tubercle of the humerus. So what does the pectoralis major muscle do? Well, it's actually responsible for several movements. Contraction of this muscle causes flexion, adduction, and medial rotation of the arm at the shoulder joint. The innervation of pectoralis major is supplied by 2 nerves, the medial pectoral nerve and the lateral pectoral nerve, which are direct branches of the brachial plexus. Next, we're going to look at some muscles of the arm, starting with the coracobrachialis muscle. The coracobrachialis is a muscle of the anterior compartment of the arm, and it originates from the coracoid process of the scapula. From here, it extends distally along the humeral shaft to insert along the anteromedial surface of the humerus. This muscle is responsible for flexion of the arm at the shoulder joint. And as for innervation, coracobrachialis is innervated by the musculocutaneous nerve, which we can see here highlighted in green. Another muscle of the anterior compartment of the arm we're going to talk about is the biceps brachii. As the name suggests, this muscle has 2 heads, both with different points of origin. The long head originates from the supraglenoid tubercle of the scapula, and the short head originates from the coracoid process of the scapula. Both heads unite to form one large muscle belly, which inserts at the radial tuberosity. So what movement does the biceps brachii perform? This muscle assists with flexion of the arm at the shoulder joint. And like coracobrachialis, the biceps brachii is innervated by the musculocutaneous nerve. The last muscle we're going to talk about today is the latissimus dorsi muscle, which we can see here from a posterior perspective. The latissimus dorsi is a muscle of the back, and it originates from the spinous processes of T7 to T12, the iliac crest, the thoracolumbar fascia, and the 9th to 12th ribs. The fibres of this muscle then converge to insert at the intertubercular sulcus of the humerus. As for the functions of this muscle, the latissimus dorsi is responsible for medial rotation, adduction, and extension of the arm at the shoulder joint. By performing these 3 movements, the latissimus dorsi earns its title as one of the swimming muscles of the human body. This muscle is innervated by the thoracodorsal nerve, which is a branch of the brachial plexus. Now that we're familiar with the muscles of the shoulder joint, let's get clinical. Today's clinical notes are going to feature the rotator cuff muscles, which stabilise the shoulder joint by keeping the head of the humerus within the glenoid cavity. The most common injuries of the rotator cuff muscles include strains, tendinitis, and bursitis. Strains or tears of the rotator cuff are caused by overuse or acute trauma, such as a sports injury or car accident. These types of injury result in immediate and intense pain and may require surgical intervention. Tendinitis refers to inflammation of the tendons of the rotator cuff muscles and is most commonly caused by overuse. This type of injury is common in individuals who frequently reach upwards, such as painters or tennis players. Lastly, we have bursitis, which causes inflammation of the bursae. Specifically, it causes inflammation of the subacromial and subdeltoid bursae, which we can see here highlighted in green. Treatment of individuals with rotator cuff injuries usually takes a conservative approach. This includes application of heat or ice packs to reduce swelling, physiotherapy to improve strength and range of motion, administration of cortisone and other anti-inflammatory medications such as ibuprofen, as well as rest. If symptoms don't improve, then surgery may be required. Before we bring our tutorial to a close, let's quickly summarise what we've learned today. We started our tutorial with the bones of the shoulder joint, which are the humerus and the scapula. We then talked about the muscles of the shoulder joint, discussing their origin, insertion, function, and innervation. We also looked at some muscles that are not found in the shoulder region but act on the shoulder joint. Finally, we finished up our tutorial with some clinical notes about injuries of the rotator cuff muscles. So that brings us to the end of our tutorial on the muscles of the shoulder joint. I hope you enjoyed it, thanks for watching, and see you next time.